Now, just allow me to share the screen. Is it fine now? Can everyone see the screen? Yeah, so I will start off with this slightly different topic that we have chosen today, and this topic is on importance of nutrition in early life. Slightly different from what we normally hear, but I think very important in our day-to-day practice. And I'll try to finish in the next 20 minutes. But the question that we have is that when we talk of nutrition in early life, which pediatricians are concerned about, is it going to affect the development on the long-term outcome of that little child? And let us see today what kind of evidence we have in this regard. Now, I take you back to a good 40 years. In 1980s, I think around 1983, there was a very famous study called the Bogota study. And this particular study in 1981 wanted to study whether nutrition in the last trimester of pregnancy and the first 3 years of life, whether it is really going to change the outcome of these small children. So they had made 4 groups. You can say group A is a group that has required no supplementation at all. Group B, only the babies got supplementation from 6 months to 3 years. And the supplementation was with respect to protein, minerals, iron. It was a combination of nutrients. In group C, they gave supplementation to the mother in the last trimester. You can see the dark bands, and in the first 6 months of life. And group D, they give supplementation to the mother in the last trimester and throughout 3 years. And when they studied the outcomes of these children, they realized that this group D did the best in terms of development, and the second best was the B group. And what these 2 groups have in common is a longer duration of supplementation. You can see 6 months to 3 years in group B, and group D lasts from fetal life right on to 3 years. So the conclusions were that when you supplement mothers in pregnancy and the first 6 months of life, so if you have a short-term supplementation, it may not last, it may disappear with time. But if you supplement in the last trimester and continue it for 3 years, you are going to have some benefits which are going to sustain for a long time. There's another famous study around that time called the Bacon-Chow study, where they gave supplementation to mothers during pregnancy and lactation. And they found that the babies had good DQ at 8 months, better development in the supplemented group. But again, this did not last. At 5 years, they found no difference in the IQ. So what happens is short-term supplementations don't seem to sustain for too long. And people are very enthusiastic. They thought, let us give a lot of extra protein and we will have a much better outcome. And they gave 6 to 8 grams per kg of proteins to preterms. And unfortunately, rather than improvement, they found significantly lower IQs in childhood. And this is a very famous Goldman study. So right from that, 40 years ago, we knew that supplementation will help you to improve the IQ. So good nutrition will help you. But if you give too much nutrition, it can cause harm. And this knowledge was with us around 40 years ago. And there is a reason for a good relationship between the nutrients and the developing brain. And you can see these 2 pictures, right, at 22 weeks, and you can see this brain at 40 weeks. And you can see the difference in how it looks. So much of growth of the brain, so much of differentiation, the neurons are going to grow, they're going to have various synaptic connections, myelination is going to occur, and there are some parts of the brain, like the auditory and visual cortices, the hippocampus, the thalamus, and the frontal cortex. These particularly are affected by nutrition. And if there are nutritional insults, then you are going to have problems with the brain. Some of them could be time-specific, region-specific, some for certain cells, which we are going to see later. There could be proliferation or differentiation, and these insults can be anatomical or sometimes even neurochemical and neurophysiological. So nutritional insults can be many. But if you have a IUGR-like situation, where there is a total protein energy deprivation, then the whole brain is going to be small. So less genetic content, less myelination, less number of synapses, and you are going to have a problem with your cortex and hippocampus. So this is a general global deprivation, and this reflects in the IUGR babies that you see. So they have a poor prenatal head growth and poor neurodevelopmental outcome. 15% of IUGRs will have cognitive dysfunction, and especially the verbal and visual recognition memory is more affected. So you see that in the Pune low birth weight study as well. And you can see this last line here, the preterm SGAs have the lowest mean IQ in this particular study. So when you are IUGR, again, you're going to be hit quite significantly. But I bring you now to the modern day neonatology. And all of us know, we've heard this word quite often. We talk of extrauterine growth restriction or EUGR. And here is a classical example of a very sick baby, not given TPN, unable to feed enterally. And you can see the growth chart, how this baby has progressively lost weight after birth. And we have babies who are stuck on ventilators, nutrition not maintained. They could be having surgical problems. And you can see this osteopenia develop, so much of muscle wasting. And these kind of EUGRs are quite common in NICUs, especially for babies with chronic sepsis, surgical problems. They get a lot of malabsorption and failure to thrive. This EUGR that we know is not a problem restricted to us. It is a global problem. And in spite of the best nutrition that you give preterms, you can see this study in 2003, nearly 25,000 preterms, when they reach 40 weeks, you can see a significant number of them are below the 10th percentile. So a baby may start off well and subsequently tend to fall off the centiles in spite of giving the best nutrition. And you can see here that if your head circumference is going to be less than 10th percentile, you can well imagine a lot of handicap. Now, this famous study by Stephens, it showed that in the first week of life, if you give 1 gram per kg extra protein, that is here, and you give 10 extra calories in your TPN only in the first week of life, you are going to have better neurodevelopment at 18 months. So you can see how important this study is, that we are doing some intervention in the first week, and we are going to get such an improvement in neurodevelopmental outcome at the age of 18 months. And this again, Ehrenkrantz study, you can see these green bars. You can just see here, these are the weight gains. You can just see one block, so 12 grams, 15, 17, and 21.2. The babies who grew the best, 21.2 grams, and you can see in all this, the smallest block here, these babies had the lowest risk of cerebral palsy and neurodevelopmental impairment, and they have the least chance of developing low developmental scores, MDI as well as PDI. And you can see this clear relationship that babies who grew the least had a higher incidence of this, and you can see a clear dose dependence that babies who grew well in the hospital seem to do better with their IQ. So in the hospital, growth would be extremely important for their neurodevelopmental outcome. So what we have seen so far is that low birth weight babies are having slow growth and nutritional deprivation in spite of the best that we are doing. And early nutrition and growth will improve their development, and EUGR also will have an adverse effect. So come what may, we have to work very hard to see that our babies are made to grow well in the NICU irrespective of their illness. So what do we mean by good growth and how to achieve it? And we always show this in utero growth chart. You can see the small baby here who has lost some weight, then grows parallel to the in utero curve, and around 40 weeks reaches the same original centile where we started. Now this is what is called as optimal growth, where you grow in the womb as you would grow like a fetus. So this comes to around 16 grams per kg per day, and people always felt that this is difficult to achieve. Some people argue that, well, you're making the baby grow, but the baby is going to be more fat, and it's going to be adiposity. It is not going to be like the baby grew in the womb. And there are quite a few arguments in this favor. But what we say is fine. You can't achieve in utero growth. At least try to achieve 10 to 15 grams per kg per day, and also monitor the length gain as well as the head circumference, because we want linear growth as well. We just don't want the baby to be fat. So this, I would say, would be the minimum benchmark if you want to babies to grow in the womb. So once it was realized that babies are not doing well, at the beginning of the century, this concept of aggressive nutrition came in. But people say do exactly what the placenta does, make the baby grow like the baby was growing in the womb. And because of that, all nutritional guidelines were revised. And 2010, we had the EPIGENETIC guidelines, which was a revision of 1987 guidelines. And in this, there were a lot of new things that actually came up, and the aggressive nutrition, you can see a Professor Eckhart Ziegler, one of the most giants in neonatal nutrition, and I had a lot of pleasure in meeting him several times at international meetings. Really a fascinating man, and he was the one who really got in this world of aggressive nutrition, starting TPN on day one, minimal enteral feeding, grading up fast, using fortifiers to improve calories, using post-discharge formula, and making babies grow well. Now, in fact, he doesn't like the word aggressive nutrition anymore because he feels that the word aggressive nutrition should not be called optimal nutrition, because aggressive gives you kind of different kind of a connotation, whether it is going to be risky or whether it is not too much. So now I think the aggressive nutrition of yesterday is called the optimal nutrition of today. And there is good evidence to show that if you really feed babies well, and if you give better catch-up, it is shown that head growth improves, iron stores improve, and you get better outcomes if the babies grow better. And if you don't grow better, then you are going to have subnormal intellectual and psychological performance, and you're going to have better nutrition is going to give you better neurodevelopmental outcome. So there is evidence to show that if you catch up, yes, you're going to do quite well. But you know, always what happens is the pendulum swings to the other side. And when we are trying to get a good brain, we sometimes move to the other side and give overnutrition. And when we talk of overnutrition, three distinct terms come to our notice. The first word called is fetal programming. So when you have a baby who is IUGR, this actually makes changes in the fetus. And this in utero environment is what is called as fetal programming, and this happens in the IUGR infant. The second word is an epigenetic change. So over generations, our genes undergo certain changes. So one experience of one generation is transmitted to the other generation. And there have been very big examples in the world, like the Dutch famine, where the fetuses and the infants were really starved. They caused permanent changes in their genes. And today also we see those changes in the generations to follow. So epigenetic changes are transmitted from generation to generation. And the third word that all of you have heard is the thrifty phenotype, which I think is a curse to the Asian population, that we are called as the thin fat Indians, very light in weight, low muscle mass, and a high percentage of body fat, especially abdominal fat. So the Asian population has this thrifty phenotype, which again predisposes us to a lot of diseases because of overnutrition. The other word that I would like to introduce here is the word called genetic sort of nutritional programming. And this word particularly is now coming up a lot in scientific literature, because it has been shown that early nutrition and genes will interact. And this nutrition programming means that nature and nurture overlap. So you have a particular birth weight, you have some experience as a fetus, and when you're born, your nutrition is going to change. So nature and nurture together cause this nutritional programming. And this nutritional programming will cause certain changes that affect long-term health. And I'm going to give you two simple examples of what do you exactly mean by this nutritional or metabolic programming. So when you feed young children, you are actually going to cause programming, and this can lead to later life infection, allergy, cardiovascular risk, brain function, bone health, and obesity. And let us see some examples on this. This is a study on rodents. Just see these two groups here. First, see on the left that these rodents were given 3 weeks of undernutrition deliberately. You can see these are the 3 weeks. And then they were fed again. But even after they started feeding again, they could not achieve their full potential. They still remained small and stunted. The same 3 weeks of undernutrition a little later, these rodents could fully catch up again. So this means that there are very sensitive periods in life where if you suffer malnutrition, you are going to get permanent affection of your growth. This particularly happens in these rodents at this particular time in very early life. And other famous study, which is known, this is a human study called the European Childhood Obesity Project. And just quickly go through 3 groups: breastfed, formula, and third group is also formula. This is low protein and this is a high protein formula in the first year. So intervention only in the first year, assessment done at 2 years. And what it shows see the top block here, though the intervention stopped at 1 year, these babies with higher protein continued to remain fat later on. And it was seen in this study that if you are given the high protein formula, you have a much higher risk of obesity throughout life. So baby takes formula only say in the first year. But if you are programming that infant for becoming very obese later on, and that's why most of these formula that you get today have lower protein than what they had in the past. So we have to be careful when we manage these low birth weight babies because they already have poor fetal growth, they could be HGA. And postnatally, if you are very aggressive with them, you are going to cause maladaptation. And because of these mechanisms that I showed you of programming, then the THRIFTY phenotype and epigenetic changes, you're actually going to cause a lot of problems in adult life. So we know that the small babies, if they are fed well, you're going to get obesity, abnormal glucose metabolism, dyslipidemia, and you are going to actually get hypertension, and you are going to face a lot of problems in later life. And this is data from Pune. This was published in Diabetes, and you can see here the x-axis has all the birth weights, and these are glucose insulin levels. And you can see the small babies. You look at the blocks on your left. You can see these very tall blocks showing that these babies who are small already have insulin resistance as early as 4 years of life. So we are talking of very early life. We are talking of our own children, and we are seeing that they already are developing insulin resistance. Furthermore, this was again KM publication. You can see the big barrier, this tall building here at the back, that babies who are small and became big at 8 years were showing the highest insulin resistance. So here we are facing a problem. These small babies, if you make them grow fast, they are going to land up in trouble. And we have plenty of evidence now that if babies catch up fast, they are going to land up in later obesity. We also have evidence with respect to hypertension, that if you have SGA babies who grow very fast, receive higher protein, you can have hypertension as early as 7 years. And you can see that this kind of accelerated weight gain may not be good from this cardiovascular point of view. Same thing about cardiovascular disease. And this particularly shows that if you're small and you grow fast, you're going to have a problem. And in fact, even neonatal growth, forget later life, even accelerated neonatal growth can predispose these individuals to cardiovascular disease, and slower growth could be beneficial. So we are really facing a problem here. On one side, we have seen that undernutrition is affecting your neurocognition and the brain. Then we are saying that if you have too much of nutrition, you are going to have metabolic syndrome. So we really are confused as to what is to be done, whether we should feed these babies fast and make them grow, or we should not make them grow very fast. And we are confused because standard conventional nutrition is causing growth restriction, neurodevelopmental impairment, and bone disease. But too much of nutrition, you're getting better growth, but you have to pay a price for it later on. You can get insulin resistance, you can get obesity, you can get heart disease. So it's really a very complex phenomenon which the world is trying to understand as to what is the right growth for these babies. And we know now that all these factors, intrauterine programming, neonatal nutrition, and childhood nutrition, all are going to affect these children. And how are we going to differentiate as to at what particular stage, how are we going to influence this cardiovascular disease in adult life? So we have two choices: feed children well, let them be intelligent, let their neurocognition be better, and unfortunately they will develop some heart disease and diabetes later. Or we say, okay, let the baby grow slowly, the brain will be a little affected, but at least the baby will have a healthy heart and no diabetes. So the choices are not very great, but we have to today find out some way by which we can actually have a better neurodevelopmental outcome as well as protect the child against adult disease. And I just show you this minimum benchmark. I'm showing this again, that apart from looking at just weight length, weight gain length, and head circumference, let us monitor body composition. Because if we are not creating obesity, then maybe we are doing well. And I saw this machine in one of the international meetings, the P-body, which actually studies the body composition of the particular person or the particular baby. Unfortunately, the cost in Indian rupees exceeded 12 crores. So you can imagine how expensive such kind of metabolic monitoring could be. But I think that will provide a final answer, that if you can cause good growth without causing obesity, maybe that would be the right answer and the right nutrition for that child. So as of today, what we say, that we have to think of the whole life of the child, and we have to balance the interests of a childhood with the likely fortunes in adult life. Now, what advice we generally give parents is that in the first year of life, focus on the brain, let the child start to grow well, let the head circumference grow. But as the child grows up, improve physical activity programs and strictly prevent obesity. I think as of now, we don't have the complete answer, but that would be a reasonably good solution to get a good brain and then avoid the metabolic syndrome. But whenever we talk to pediatricians, they're quite fed up of breastfeeding because we hear so much of breastfeeding all the time. And we know its importance already. So people feel, Baba, why this breastfeeding all the time? But now what has happened is that there is an association clearly seen between breastfeeding and IQ. And you can see here at the bottom, if you're a low birth weight baby, you're going to get 5 higher IQ points if you're breastfed in the first year. And if you're normal birth weight, you're going to get 3 IQ points which are higher. And you can clear association. Longer duration of breastfeeding, better is the IQ. And now people know that breastfeeding has a profound impact on adult intelligence. And I think this is a very important thing to know, especially to motivate mothers for breastfeeding. Some long-term effects like breastfeeding in the long term, forget infections and allergies, which you already mentioned, but the entire metabolic syndrome is going to be less on breastfeeding, lesser systolic, diastolic BP, better cholesterol, less diabetes, less obesity. You can see very small numbers here, 0.5, 0.5. So I was wondering whether these very small numbers can really affect adult health, but I was told that this is population statistics. So if the systolic blood pressure of a population drops by 1.5, apparent incidence of strokes drops by 11%. So at a population level, these small changes make phenomenal difference to the health of the population. Breastfeeding for a longer duration is one of the greatest interventions to prevent adult obesity. And a clear relationship that every extra month that you breastfeed, the risk of obesity drops by 4%. So this impact of breastfeeding on intelligence, metabolic syndrome, and obesity should not be forgotten because these are the real long-term effects of breastfeeding. I'm just going to quickly touch upon some specific nutrients and the brain. And you can see iron extremely important. Even your basic cord ferritin also can affect your neurodevelopment. So see that all these low birth weight babies have very good iron stores. Sometimes when these babies are supplemented, I do check their serum iron and their ferritin and I optimize the iron, especially in the first 2 years of life. Many a times pediatricians prescribe multivitamins and calcium and vitamin D. Many a times iron is forgotten in the small babies. Zinc particularly important for the SGA baby and very important for the orbitofrontal cortex, temporal lobe and cerebellum. So whenever you write a multivitamin, always write a multivitamin containing zinc, especially for a SGA baby. And the SGAs particularly, you must be careful of giving zinc, better catch-up growth and lower mortality. Then of course, some nutrients like copper, very important for the cerebellum, LC-PUFA, very important for the eye and the cortex, visual cortex. So you must be careful that all these nutrients are really looked into very well. Lot of discussion about DHA supplementation, but most of the data is in favor of maternal supplementation now, because maternal supplementation leads to better DHA levels in the baby, including in the breast milk. DHA, of course, these are the Western data, but I'm very sure that DHA to the mother is going to improve the brain function in the small babies. So I would like to conclude my talk, and what we essentially saw today, that achieving adequate nutrition the first few days of life is a challenge, but still we have to meet that challenge. We have to be aggressive. We have to give early parental nutrition. We have to feed enterally. We have to use breast milk, use fortifiers, see that the babies grow at least 10 to 15 grams per kg per day. We should avoid postnatal malnutrition, and we now have our nutrition strategies in place, and we have to see that we follow them. We have seen that early nutrition and growth in the NICU affects metabolic health as well as intelligence. I showed you some examples of this nutritional programming. And early nutrition affects growth, IQ, allergy, obesity, as well as risks of adult disease. Specific nutrients affect different processes of brain development. I showed you about iron, zinc, and I showed you about copper and how they would affect different parts of the brain and how we must maintain good micronutrient levels. And finally, breastfeeding is just not milk. It's just not nutrition. It is much more. And we today saw some long-term effects of breastfeeding, especially on IQ. and on heart disease as well as diabetes. So whenever we have these small babies in the first few years of life, let us really think of nutrition, because we know that today's nutrition is going to be tomorrow's outcome of these babies. Thank you very much.
Thank you very much, sir. Thank you very much, sir. It was indeed great pleasure to listen to your talk. And many of the facts you present are very much evidence-based, and we are very much clear that it is not only the nutrition from the postnatal period, that is antenatal period. Fetal growth is affected by the nutrition, and a lot of factors. It's not only the nutrition, like epigenetic factors play a role. And is nutrition at right time with optimal dose and optimal duration is very much essential, not only for physical as well as long-term neurodevelopmental outcome. We are very much pleased to have your talk, and we will take some questions. We have time.
Yeah.
Sir,
yeah, you have time.
Sir, about iron supplementation, always when they are micropremies and preemies, when we start iron, always there is a confusion like when to stop it, like whether we ideally check every time or we just continue for 2 years or 3 years.
Yeah. See, as I mentioned, one is that we should never forget to prescribe iron for the small babies. And generally iron is started at 4 weeks. It's very easy to remember that after baby is 1 month old, so born on 13th or next 13th, you should be starting on iron if you're a preterm baby or a IUGR baby. So 4 weeks for iron, in a preterm, 4 months for a term, and duration of iron supplementation recommended by all bodies is around 12 months. Okay. So 1 year. But the dose of iron is very important, because smaller babies, the dose of iron supplementation is 4 milligram per kilogram per day. And if you're a slightly bigger preterm, above 1.5 kg, dose is 2 milligram per kilogram per day. So when we supplement, it's not good to just write 5 drops BD or 3 drops BD. One must actually find out how much iron we are giving. If the baby is very small, say below 1250 grams, it's always better to check the hemoglobin and the ferritin levels at least around 3 months and 6 months to just optimize the dose of iron. Because as you know, hemoglobin alone is not a good marker for iron status, and the tissue iron we cannot pick up by hemoglobin. So that's the reason why in the small babies, we not only give iron, it is important to monitor their iron status. And along with iron, we also monitor their osteopenia. So we check their calcium, phosphorus, alkaline phosphatase as well. And sometimes the dose of your calcium and vitamin D and iron may have to be a little bit titrated correctly, because we give the same doses for all.
Okay. Yeah, sir, that's very good information. And so one more question, like when many of the neonates, those are extremely like low birth weight with IUGR, when we take the follow-up, parents say they're eating well, everything is fine, still they are not growing. So we use protein supplements, they are not anemic, still they are not growing. So how to counsel them?
Yeah. What we essentially do is, you know, first of all, whenever you have a preterm low birth weight, this is very, very vital to have a growth chart. And many a times, even in my practice, I sometimes realize that I've forgotten to really plot the growth chart of their child. So nowadays I've started giving fathers that responsibility. Because mothers have many things to do. If you have a growth chart and tell the father that every time you come, please plot this chart. A lot of fathers are enthusiastic about plotting the chart. So better have a look at the chart of that child. So with the growth chart monitoring. Secondly, whenever this child is not eating at all, I give them a pen and a paper and tell them, please write down what the child is actually eating on an average day with the quantity of the child also. So when they write down, you certainly realize that many diets that I've seen are reasonably good in there. Maybe there is enough milk there. Sometimes there is enough amount of carbohydrates there. But many a times I see that the proteins are very insufficient. And then that sometimes becomes a limiting factor for growth. So always see whether the intake of milk, carbohydrates, proteins, and fruit vegetables, there is the balance. And when they write down, they will write dal rice, they'll write roti, they'll write shira, but there is no protein anywhere in that. So you find that little bit of dal which the child is getting once in a day, that is only protein source. So you must see that proteins are improved in the diet. there is sufficient physical activity, and always check the hemoglobin also, because most of these kids hemoglobin is hovering around 10.5 or 11. So unless you check it, you will not know. So this is how I approach that, and protein deficiency is one of the reasons why these kids grow slowly.
Okay.
All right. I think we have another question we can take.
Yeah, one question is there in the chat box, Vijay. You can ask.
Yeah. I'm not able to see that. So
Growth charts of the HGA babies.
So you can ask. I'm not able to see the chat box question.
Yeah. Like, can you, sir, please comment on the use of Fenton or intergrowth charts for the monitoring of HGA babies, which is preferred?
Yeah, I think the most recent chart is intergrowth.
Okay.
But even we at KM are not using intergrowth, because we had printed a lot of Fenton chart in our case papers. So Fenton, intergrowth, you can use either one of them. But I think if you ask me what is preferred now, most of the research organizations now recommend intergrowth. But
okay.
I must admit here that KM we are still using Fenton.
Okay. Thank you very much, sir. It was indeed a great pleasure to listen to your talk.
Sure.
It was very enlightening to everyone.
Sure. Yeah, and wish all of you a very happy Diwali.
Thank you. So wish you.
Yeah, thank you.
Sure.